Thank you, remind me. Threats to neurosensory. All right, ICP. It is made up of three things. This is kind of review, all right? CSF, which is about 10%, blood about 12%, and brain, which is about 78%. You do not need to know the specific numbers. I would know that your brain takes up most of it and your CSF and blood are the other parts. Normal ICP is 5 to 15. If it's elevated above 20, sustained, then we get into trouble. But basically, anytime you have any ICP greater than 15, that's a concern to you as a nurse. And we're going to talk about why. That means that the pressure inside that head is too much. Something, CSF is too high, blood is too high, brain is bruised and too big. Something is causing pressure within that head. So anything above 15, the other factors are going to be influenced, and we have a concern. We're going to talk about these a little bit, but you as a nurse need to understand that there are lots of things that influence ICP. So when you're taking care of your patients that has a head injury, that has a brain bleed, that has something going on, you're going to be careful about these things. Anything arterial, venous pressure, abdominal thoracic pressure, that's really important, right? Because if you have a patient that's bearing down or constipated and they're trying to push to go to the bathroom, they're going to increase their ICP. You don't want to do that for your patient that's got high ICP. So you're going to be making sure they're on what? Stool softeners, right? The way they're postured. Obviously, how do we want our ICP patients, high ICP patients to be? Yeah. Up, right? We don't want them super flat. Yep, exactly. We don't want them too high because we don't want to increase that pressure in their belly, but we don't want them laying flat either. Their temperature, even blood gases, high CO2 can cause increase. Oh, it's okay. No one freak. So everyone's heard the Monroe-Kelly doctrine, right? Basically, those three components, brain, blood, CSF, have to remain at a constant within a closed skull structure. If any of these volumes increases, a volume from another component must decrease. That's the Monroe-Kelly doctrine. They have to remain at constant. If any one increases, the other must decrease. So let's say you have someone who was in a car accident, hits their head, they have a brain contusion, right? Their brain's a little bruised and swelling. So the blood and or CSF have to decrease to make that even. Is having a decrease in blood to the brain good? No, because what does blood carry? Oxygen. So we don't have oxygen going to the brain, so we have ischemia happening. So, but there's this constant. So in that, this ability to compensate is very limited. One of those will compensate for just so much before the whole kind of system starts to fail. So how do we maintain ICP? 1, CSF. We basically alter absorption or production. So CSF is produced at a certain amount. You guys don't need to get into how much is produced at what percentage or anything like that, but just know it's produced at a constant amount. If for some reason it's produced too much, like when we talk about hydrocephalus, or produced too little, we're going to have altercations in that. Also, the absorption, as CSF is produced and absorbed in the same 1-to-1. As much as it's produced, it's absorbed back. If for some reason there's a mismatch in that, we're going to have high levels of CSF. Or displaced fluid. Blood. Collapse of veins, right? So if any arteries or veins get collapsed, either from pressure because of a swollen brain, or if you have large ventricles, so the CSF is high, and you have these large ventricles compressing. We talked about constriction and dilatation. Obviously, if blood vessels are constricting, then we're going to have less blood flow. If they're dilating, we're going to have engorged blood flow. Or change in the outflow. And then brain. That dura, which we're going to talk about in a little bit when we talk about head injuries, or compression of the brain tissue. So this should all be pretty much review. All stuff that we've talked about, but it's important to understand, especially when we're taking care of our critically ill patients. So brain, blood, CSF. Oh. So like we talked about, if anyone, so we have brain here, and if for any reason the brain it's going to kind of flow into our blood, right? Flow into our CSF. So we have less blood, less CSF. If it's for some reason blood, so this should only bleed blood. If now all of a sudden we have a bleed, we have blood pushing into brain, right? Brain compression. CSF, normal CSF. If for whatever reason we have an increase in production or decrease in absorption, it's going to push into brain also, or it's going to constrict blood flow. So they only have a limited ability to compensate. So auto-regulation is really important, because the most important thing we want is that consistent cerebral blood flow. That's CBF. So no matter what, we want blood going to that brain. We want oxygen. We don't want the brain to get ischemic. So the body's going to adjust, has that auto-regulation. So it's going to adjust the diameter of the blood vessels to have that consistent cerebral blood flow. So in order for that to happen, your mean arterial pressure has to be between 70 and 150. So that's where you guys, the nurses, come in. We need that amount of pressure to push blood into the brain. If you're taking care of your patients and you don't have MAPs of greater than 70, then you're not getting enough blood flow to the brain. We're going to talk about CPP next. So cerebral blood flow, the cerebral perfusion pressure, is that pressure needed to ensure blood flow to the brain. Your cerebral blood flow is that MAP minus the ICP. So your MAP is really critical to maintain with a high ICP, right? Because real quick, MAP, normal, is 60 to 100. Anything less than 50 autoregulation fails, so that dilation and constriction of blood vessels to keep blood flow at a constant, anything less than 50 for your CPP, your autoregulation fails. That's when you're going to start having ischemia to the brain, neural death. So it's really important to maintain your mean arterial pressures as if you have high ICPs, right? Because if normal CPP is 100, so in your MAP, let's say, is your ICP's normal is 15. So if you have a MAP of, that's not wanting to work. If you have 115, right, a MAP minus 15, your ICP, then you're at 100, right? Okay. Now, what happens if all of a sudden you have a MAP of, this is going to be crazy, 100, and you have an ICP of 50? What happens to your CPP? It's 50, right? So do you see how as your ICP goes up, your MAP has to go up to get you a normal CPP? Okay? That's why it's really important that you guys are monitoring, again, those silly vital signs, those silly assessment skills that we think are kind of mundane are really important, because you guys are going to notice these changes, and if your MAP is too low and you have a patient with ICP, you should automatically be thinking, my patient's blood flow to the brain is not happening like it should.
What about MAP that's over 100?
Well, we're going to do a example. So let me give you, my stupid pen's not working. I'm really mad right now. I'll write it on the board. So let's say you have a blood pressure of 106 over 52. Okay? And your ICP is 14. Is that a normal ICP?
Yes.
Okay. So the way you calculate MAP is by diastolic blood pressure. I just want to make sure I tell you the right thing. Minus 1/3 systolic minus diastolic. I would know how to do this. If you have a different formula that you like, I don't care what you use, as long as you know how to do MAP, okay? So if there's a different formula, by all means, tune me out for 2 seconds and do it in your head the way you do it, but I would know how to calculate MAP, all right? So the MAP for this would be what?
70 the way I do it.
Okay, how do you do it?
I take 106 plus 2 times 52 and divide it by 3.
Okay. Okay.
Yeah.
So 70's right, yep. Yeah, and that's why I have NIPS come in and teach you all, because I learn math way different than y'all. It's like trying to teach my kids that Common Core. So I don't want to confuse you. So whatever you learn, if you don't know how to do MAP and you want to learn from one of your friends, do. If not, this is one way to do it. But I would know how to calculate MAP. So if your MAP is 70, okay, with this blood pressure and this ICP, what's going to be your CPP? Can you guys see over there? I'm sorry.
56.
Right? Because what's CPP? CPP is the MAP, right, minus the ICP. And what is that? Is that great blood flow? Is that good perfusion pressure? No. Your brain, with that, so even though you have a normal ICP, right? This is considered normal. You're not getting enough pressure. You're not getting enough perfusion to the brain. You're going to start seeing signs of ischemia. Okay? So as your ICP creeps up, because it's a pretty big number. What if the ICP was 5? What would be this number? What would be the CPP? 65. Are we now okay?
Yes.
Mm-hmm. So as our ICP creeps up, that that MAP needs to creep up to compensate. That's why it's so critical in maintaining cerebral perfusion. If this does not make sense to someone, tell me so I can do it again.
Could you
Okay.
write it out with the numbers? Because I don't, is that a minus? I don't know what that is, that dot.
Yes, I'm sorry. This is a minus. Okay. I apologize. So, again, cerebral perfusion pressure is dependent on good mean arterial pressure. You get your mean arterial pressure from your blood pressure.
Dr. Daniel,
Mm-hmm.
I always add 1 systolic blood pressure plus 2 times the diastolic divided by 3. Why is
That's
it
the other way. Okay, so tell me your way so I can write it up here for everybody. What?
1 systolic,
Systolic?
1 systolic blood pressure plus 2 times the diastolic blood pressure divided by 3.
All of it.
I don't know, they're equally confusing to me. So.
That makes it easier because you go 1, 2, 3.
Yeah, that's fine. Yeah, so I don't care which way you use. They will both get you the same number. Okay? Take a picture, write it down, lock it to memory. But in order to maintain your cerebral perfusion pressure, your MAP, which is calculated one of those 2 ways, and because I can't write on this screen since I'm writing it here, I'm going to just say it so that when you listen back. Your MAP is calculated by your systolic blood pressure plus 2 times your diastolic blood pressure, all divided by 3. So that you calculate your MAP by a given blood pressure, right? You've got your MAP, and they're going to give you ICP. In order to get your CPP, your cerebral perfusion pressure, it is your MAP minus ICP. Which is, it is written right here. So as you can see, even with a quote-unquote normal ICP of 14, if you don't have a great blood pressure, you're not going to have good perfusion to the brain. Is that making sense to everyone?
Is ICP always given to us?
Yeah, because you'll have some kind of ICP monitoring, and we'll let you know that. You don't have to calculate ICP. Yeah. So that's why it's so important for you guys as the nurses to be on top of this. Because you are going to be at the bedside, and you're going to notice, my ICP's creeping up, my blood pressure's really not doing a whole lot. I'm a little concerned that maybe my patient's going to be at risk. Because we're trying to make our patients not die, right? Or have as least loss of function as possible. All right. Are we good here? Everybody good? All right. So why do I care about this? Because increased ICP is life-threatening. Any increase in any three of those components, and they're at risk for increased cerebral edema. Oh, did I skip one? I'm sorry.
Stage 1, 2, 3.
Oh, basically, stage 1 is total compensation. You don't need to get too in depth. I don't know how that happened. I'm sorry. Stage 2, you have some decreased compensation, and they're at risk for high ICP. Stage 3 is failing compensation. So this would be, right, failing compensation here. And they're going to start having clinical manifestations of high ICP. And we're going to talk about that in a slide or two. And stage 4, why we care so much, is that if we have high ICP, where's the brain going to go?
It's herniated.
It's going to herniate down, and that's death. And that's scary. I've had that happen to me once, and it was horrible.
So you want us to just put brain herniation for stage 4?
Yeah.
What are they like?
It was a bad trauma patient. I worked at Tampa General for 5 years in the trauma unit, and we're a level 1 trauma center. And it was just a bad car accident. And I was literally doing compressions on them as we were, like, going into, like, I was on top of them in the stretchers, like, we are going up to surgery, and they just didn't make it. They just died. It was horrible. So it's really important to catch early signs and symptoms of this, because they can move slowly to one of these stages or very quickly. All right. So we talked about that. So obviously, well, like we just said, the lower your CPP, your cerebral perfusion pressure, you're going to have brain ischemia and infarction. So the higher your ICP, what's going to go down? CPP, right? They're inversely related. So the higher your pressure in your head goes, the less blood flow that's coming to your brain. The less blood flow coming to your brain, the more ischemia and infarction you're having. There's this whole process of why that cerebral edema happens. Because of the ischemia and infarction, it causes cells to swell, and that's what causes the edema, and that's what causes the herniation. That gets way advanced into the patho. If you guys have the concept that basically as your ICP goes up, your perfusion goes down, and it causes ischemia infarction, that's where we need you to know. This is in your book, and it talks about that patho. Like I was just talking about, it goes really in depth. If you are really interested, or if it helps you understand, go through it. So cerebral edema, it's extravascular fluid on the brain. It's caused by a lot of things. Masses, lesions, head injury. The most common is vasogenic. This is where intravascular fluid goes extravascular and causes cytotoxic. This is not like an anoxic event. You're near drowns. Basically, fluid shifts into the cells and causes the cerebral edema. Or interstitial, then it's like hydrocephalus. And that's where the ventricles are large, secondary to like high production.
What does your second one say? EV to what?
extravascular into the cells.
Oh.
Mhm. Secondary, I'm sorry. I use shorthand because my hands get as tired as yours. I wouldn't freak out too much about this, okay? I would understand that it's there and that there's different things that are causing it.
What's it say there's a cytotoxic EV?
Extravascular. So fluid is moving extravascular into the cells. All right. So some general clinical manifestations for high ICP. These are the things that you guys are going to take into account along with, my blood pressure's not great. Oh, they're being monitored for ICP and it's creeping up. Are they showing any signs that their CPP is not high enough? What are some early signs? What's the most early sign?
Increased level of consciousness.
Decrease, yep, LOC, good job, guys. Some kind of change in LOC. And people want this to be very dramatic. They want it to be like they're in a coma. If they're in a coma, you have waited too long. Okay? This can be just as mild as a flat affect. It's any change in their level of consciousness. Okay? It's why, like, when you have a headache, you're not as nice. Or you want it quieter. Or, like, you know, people can tell because I am normally very bubbly and obnoxious. And when I don't feel good, I get very quiet. And they'll be like, oh, what's wrong? They can tell because my affect has changed. Because my pressure is probably a little high because I have a headache. So it's something as simple as that. If you go in and see your patient in the morning and they can tell you their name and the date and the president and all that, and then you come back in and they look a little confused, that's an early sign that something may be happening. Okay? Especially if you have a patient that's at risk for high ICP. It's really the most sensitive of all the neuro. And it goes anywhere, like I said, from flat affect all the way to coma. So yeah, you may get something like a patient that is sleepy or difficult to arouse or not waking up at all, but by then we're pretty significant then. But any kind of change in LOC is one of our first indications that there's, any change in, LOC, indications that we have high ICP. Changes in vital signs. Does everyone remember the Cushing's triad? I'm kidding, kind of.
High blood pressure.
Yeah. High, what kind of blood pressure? Systolic, right? They get that widening blood pressure. Irregular respirations. A lot of people want to say low respirations or high. It's not a change in the number, rate, but they're just irregular. With a low heart rate. And that heart rate is full. It's bounding. So it might be only 40 beats or 50 beats per minute, but it's like boom, boom, every time. Is this an early or a late sign?
Late.
This is a late sign. They were going to tell us before. You can have changes in body temperature. You can have ocular changes, eye changes, right? I'm going to put them all up here, but if you put eye changes, I think you've got the picture. They can have one side pupil dilated. They can have a sluggish response. They can have no movement of the eye upward. They can get ptosis where the eyelids kind of droop. They can complain of blurred vision. So any eye changes. What's one that we always think of when we think of high ICP? Like, huh? Huh?
You talking about manifestation?
Yeah. Yeah, headache. I thought that was next, but it's not. But yes, headache will be on there. Vomiting. And typically, do they have nausea with that vomiting? No, there's no nausea with that vomiting. They're vomiting because of pressure, not because their stomach's upset. They can have decreased motor functioning. And they can have responses to any kind of painful stimuli. So basically, when they posture, that means their brain is irritated. So decorticate, decerebrate, they can do one and not the other. The other pictures, I think the bottom one is them doing one of decorticate and one of decerebrate. But they can posture.
This is the third one.
The
last one you say you kind of.
Oh yeah, the last one is some other one that we don't need to get that much into it. Vomiting, no nausea. Oh, I'm gonna go back. Don't freak. Okay. So these are all things that tell us that our patient's having high ICP. But now we're past the point, right? We're in level 4. So I don't want you to just tell me that your patient's having ICP. I just don't want you to be like, oh, okay, I calculated the CPP. I know that they're not having cerebral perfusion, and I know they're having clinical manifestations. I want you to now tell me what you're going to do about it. Yeah. So and if you have things that are bothering your patient, like that are increasing the ICP, what are you going to do? Take them away. So if you're doing things like what we talked about in the beginning, things that cause them to increase their ICP, like if you're suctioning them, if you put them too high, if you have them low, then we're going to change it, right? If we're irritating them and we're causing them to posture, we're going to stop. We're no longer, again, this is where we got to change our thinking. We're no longer just asking you to calculate and tell us. We want to know how you're going to intervene. What are going to be your priorities? What are going to be your interventions? How are you going to take care of this patient who's showing these symptoms? All right. So how do we measure ICP? The GCS. You should know how to calculate GCS, especially all those that are telling me they want to go into ER. Basically, it's a quick way of determining what? The level of consciousness, right? And if it's less than 8, intubate. Yeah. All right. What's the lowest score you can have? 3. You can't really get lower than a 3. So if you see someone write like a GCS of like 2 or 1, they probably miscalculated. So, okay. So I would know eye opening 4, verbal is 5, motor is 6, and what they're doing. The top scores, everything's moving by themselves. They need no help. If they're a little low, like a 12, 13, 14, they probably need some kind of stimulation. Either they have their eyes closed and you ask them something and they open their eyes that way, or you have to like kind of wake them up. But anything less than 8, we intubate. So how do we measure ICP? What's the gold standard? Yes. Ventriculostomy is the gold standard. This is how we're going to measure our ICP. So it's a drain that goes, it's a direct measure of the ventricular pressure. And it can also drain CSF. So for some reason, we have pressure because of a bleed or because the brain is kind of swollen. We can put this drain in to measure ICP and also to help drain some extra CSF. We can administer meds through this. It's pretty cool. And a transducer needs to stay at the level at the ear. So everyone see this little flap? Everyone touch their little flap? That's where your transducer needs to stay. The tragus, tragus, is that how you say it? That's where it needs to stay. Not at the top of the ear, not down below, but right here. So if your patient goes up, does your transducer stay here? No, you've got to move it up. If you put your patient down, is it going to stay up here? No. What could you risk if you don't put that transducer with the patient?
Pressure going up and down.
You're going to cause the pressure to go way up and down, or you're going to dump a bunch of CSF out of your patient, or you're going to cause a backflow of CSF, not allow it to flow out. It's not going to work the way it's supposed to. And every time the patient's repositioned, that system needs to be zeroed. In order for it to have correct readings. So typically what you're going to see, they're going to put this little catheter right into the ventricle, okay? I wonder if I can. So they're going to take this. This is the, right? This is the little catheter. You're not going to see that. This is going to be, this is the drain that you're going to see, and this is the transducer right here. Obviously, there's going to be more catheter than that, okay? That is the transducer that you need to keep at the ear. On there, they typically have either a 3-way stopcock. Does everyone know what I'm talking about? Like the little button that goes, the little white flap that can go either way. So they'll have either a 3-way stopcock, or a lot of times it will be flat with like a little blue rubber thing that you can pull up. Has everybody seen those or no? Don't freak out too much if you haven't. That's how you zero the system, is by moving the stopcock or zeroing it. You will learn that if you go into an ICU setting, because obviously, are these patients on the floor? No, these are critically ill patients. So they're going to go into an ICU. You'll learn how to zero it. But it's important for you to understand that you do have to zero it. Does that make sense? Mm-hmm. So I care less about how right now and more that you need to. Yes, Christine? Typically antibiotics to treating any infection, so you can get directly to it. All right. Huh? No, you typically don't give a blood pressure med or anything like that. And so this is the transducer. That's what needs to be kept at the level of the ear. And then you'll have drainage. I'm picking it. Then the CSF will drain into this bag. And this is a closed system, obviously, right? High risk of infection. So we got to be really careful.
So, the only time you would zero out is when you have the reposition?
Yeah, most places have policies where, like, you have to do it once a shift. Like, I know when I worked in ICU, I would have to zero all my lines once a shift, or anytime I moved the patient. But you would follow the policy of the facility that you're at.
Is it called zeroing?
Yep.
It is.
Mm-hmm.
So zeroing is different from repositioning the drainage system? Because when I was there, they had a laser that they had to point at the man's ear. So like if you raised the bed a little bit, you had to move the system to put it back in his ear.
Yeah.
So that's different from zeroing?
Yeah, zeroing is typically like where you zero out the system. And every machine and everything's a little bit different. So I wouldn't freak out too much about knowing how to zero it. I would understand that your responsibility as the nurse is, if you have a patient like this, that you need to zero out the system as they're repositioned. Does that make sense? You'll learn how to use your facility's equipment. They'll teach you. That will be part of your training. So you don't need to focus too much on how, because I could tell you one way, and you're going to go to a facility that has a different drainage system, if that makes sense. Am I answering your question?
Yes.
Okay.
Okay, what does zeroing out mean? It's not like the amount that's in the drainage system.
No, zeroing just means like basically starting from baseline. It's like having a baseline heart rate. Okay? So let's say your baseline heart rate is 60, and that's where we need to see it. But when you exercise, it goes up, and now when you calm back down, we want you to go back to baseline. or if you're sleeping, it goes down, and when you come back awake. So that's how the system works. It has to be zeroed. If it doesn't get zeroed when you move them up and down, you could have readings of ICPs that are too high or readings that are too low. So now, if you calculate, you don't zero it, and it's telling you a reading of an ICP of 5, but your ICP is really 14, you're going to think you're okay when you're not, right? So we base a lot of drugs and interventions and medications on what our ICP is reading to us. And if our measurements aren't accurate because we're not taking care of the equipment the right way, we're going to be treating based on inaccurate measurements. And when you have something, remember we talked, these are slight variations we can have. It's not, we have limited compensation happening here. So if we are basing our treatments off of inaccurate information because we didn't do our job and zero the equipment, and we have limited ways we can compensate, we could really end up screwing our patient. All right, any more questions about that? Oh, things that we need to do, obviously, like I talked about, I got ahead of myself. It's a closed system. We really need to prevent and monitor for infection. We got to level 4, so everybody knows what signs and symptoms of infection. Temp, color of the CSF, drainage. Oop, I'm sorry, no freak out. So we need to look, if that CSF, which is supposed to be clear, is coming out cloudy, then we have an issue. We would want to do what? Call the provider, right? If we notice that the patient's temperature is increasing, if we notice drainage around the site. All right. So, if we have ICP, high ICP, what's one of the first things we can do to treat it? Well, you guys are right. We want to identify what's causing the high ICP, right? Get rid of it. Treat the cause. That might mean surgery, though. We're going to talk about brain tumors in a little bit. What are our ABCs? Airway, right? So if we have a patient that their ICP is real high, and we have a GCS of 8, we're going to intubate, we want to make sure we have a patent airway. Because if we don't have an airway, they can't breathe. It doesn't matter really how much we're pumping to that brain, right? O2, what are we going to do about suctioning? Are we going to suction the crap out of them? No, we ain't. We're going to be careful because that's going to raise their ICP. Someone said mannitol. Yeah. If they have a lot of swelling of the brain, what does the mannitol do? It pulls that fluid back off, right? So it pulls hypertonic solutions, right? Pull fluid out of the cells. Corticosteroids can help decrease some inflammation. So all those things help decrease the ICP.
But you don't use that for a head injury, corticosteroid, right?
No, we're just talking about in general. We're going to get specific to head injuries in a bit. We're talking about like ICP in general right now.
Okay.
Nutrition, fluid and electrolyte balances. We said ABGs can alter. Preventing any complications secondary to immobility. We kind of beat this dead horse. Head to bed 30. Remember, we have to be careful because anything that increases ICP, like turning, coughing, bearing down, we want to try to avoid or minimize as much as possible. Pain and fever control. We said if you have pain, your ICP goes up. If you have fever, your temperature's high, your ICP is going to go up. What are we going to keep that CPP at? Above what? Above 60. Your systolic blood pressure needs to be above 100. And then, as always, psychological considerations. And when we talk about head of bed, and Scott said it, we want to be careful about putting them up too high, okay? Because just like keeping them low, putting up too high, we flex that, neck or hip. We also increase that ICP, right? Because anything that increases the abdominal pressure can increase ICP. All right, again, you don't need to write these. These are just, if you have a patient, just ways to kind of think about it. Decreased intracranial adaptive capacity. That's really related to decreased CPP. Risk for ineffective cerebral tissue perfusion. Risk for disuse syndrome. All right. Do you guys want to take a little break? All right. You've got you have 7 minutes. Is that a nice compromise between 5 and 10?